What we are going to discuss today is related to your field. We're going to be talking about safe surgery, ensuring safety in surgery. So let me read this. I found a publication, although done in the United States, published in the International Journal of Surgery 2020, Trauma of Major Surgery, a global problem that is not going away. About 310 million major surgeries are performed each year, around 40 to 50 million in the USA and 20 million in Europe. It is estimated that 1 to 4% of these patients will die. Up to 15% will have serious post-operative morbidity, and 5 to 15% will be readmitted within 30 days of the surgery. I was trying to find Nigerian statistics in terms of surgery, but I didn't find any study quoting statistics of complications or morbidities or mortalities that arise from surgeries in Nigeria. Maybe I didn't search enough. I'm sure there's something out there, but I know for a fact that the figure quoted in this US study, it won't be the case in Nigeria. To be fair, we've had cases of people dying immediate post-op, people forgetting gauze or forgetting foreign bodies inside people during surgery. So I know there are different factors that can lead to problems with surgery. So you will be doing more of the talking because it's your field. So tell us about safe surgery. What are the factors really that can help prevent all these morbidities and mortalities that exist or associated with surgeries?
So the thing is, the study you quoted in the US, they are probably able to get this kind of studies from a central bank.
Yes.
So what we probably have, because our registries in Nigeria and this part of the world, they are not as developed. So we don't have a central registry that you log in the details of every case that you do. So if you have that kind of bank, then anybody can pull out that information very easily, but we don't have this kind of thing. So what we have is individual studies from different centers telling us the morbidity or mortality of some particular procedures.
All right.
Yeah, so you might not be able to get that
something for the whole of Nigeria.
So surgeries are done every day. And like I always tell patients or tell people, surgery can actually be very, very safe. Very, very safe. And it's in both climes. I mean, the places where you say surgeries are very safe, it doesn't mean that there are not many mistakes.
Definitely.
So some days ago I saw the story of a surgery in the US where a patient died because they removed his liver instead of his spleen. Now, for any lay person, that may not mean anything.
Liver be removed instead of spleen?
For a lay person, it might not mean anything to you. I just like those doctors, they come with their mistake again. But for any medical person, especially a doctor, you will know that the height of error in surgeries for you to remove a liver instead of a spleen.
How?
Because they are just so different. So different in the anatomical locations. Of course, they are both in the abdomen, but so different in the circumstance in which you would even want to remove someone's liver.
Yep.
So, I mean, a surgeon goes in for a laparotomy. They are supposed to remove the liver of a particular patient, and then they are supposed to remove the spleen of another patient.
Oh, there was now a mix-up.
Yes, and then it then goes and says, "Oh, thinks this is the one
I'm supposed to
remove the liver."
Just I watched a movie. I'm currently watching a movie called The Residents. It's on Netflix. Oh, am I even supposed to say that? Okay, I don't know. I'm currently watching a medical movie, and in that movie, the surgeon removed was supposed to remove a testicle, the bad one, and then removed the good one. Made a mistake of removing the good one.
Yeah.
And abroad, is the scrubbing and all that. The place is already marked. I think there was a mix up in the process of cleaning and all that. The line got cleaned off, and I don't know what happened. The surgeon did not reconfirm and then removed the good testicle.
Yes, so it sounds like an horror movie. Yes, but very, very easy, and it happens mostly in developed countries.
Yes,
it does. So, like I said, of the story I mentioned, I said this one cannot happen in Nigeria. You know why? Because every patient I operate on, I know them
personally.
Yes,
you established a rapport.
I would have looked at the files. I know what I have on the list.
Okay.
The following day. It's not like what happens in some places where they put patients on the list for the surgeon.
Oh, I see.
So if you are preparing the list for me and I don't know what is on the list, then that kind of error can happen. But if I'm the one, I know the list, I say, oh, put this patient. So I'm saying,
and you've interacted with the patient.
Mr. Ambrose, that man that has a splenic tumor, put him on the list for tomorrow. And I get to the theater and I know Mr. Ambrose. And I see Mr. Ambrose there and I see him on the table. There can't be any error. But there, what they've done is there's a lot of division of labor.
All right.
The surgeon may not be in theater when they're anesthetizing the patient. So they've anesthetized the patient, they've cleaned and dripped the patient.
Drip the patient for you.
For me.
You just walk in.
I just walk in and I say, but what I'm supposed to then do is to confirm. Yeah. To say, oh, is this Mr. blah blah blah? Is this
Mr. Let's reconfirm and all that.
You know. So if you don't do that, there will be errors. If, like the testicle story you mentioned, if I get into theater and I say, is this Mr. this? Oh, that guy that had testicular torsion, we are doing this and this. If I don't do that in developed countries, of course there will be errors.
All right.
But in Nigeria, if I have Mr. Saliu that has a testicular tumor and I say put Mr. Saliu on the list, I get to theater tomorrow, I'm going to look on the table and see that, oh, this is Mr. Saliu. And then I know the testicle. I'll simply ask, what side is it we're operating on? Says right. Oh, and I know it's Mr. Saliu, so it has to be right.
But in Nigeria, are there no times that you have to operate on someone that is not primarily your patient, or let's say they call you for an emergency, you don't ordinarily cover the place.
Maybe the hospital.
And yes. They call you.
So that kind of thing can happen in that setting where they just call you in. They've given you a story.
Yes.
And then you go. But you see why it's all still different is that the system is not as developed. Is not automated. Okay, I give you an example. There are some problems you cannot have in driving a car if you are not in cruise control.
Okay.
So if you are driving a car and you put your car in cruise control, the chances that you will gist with your friend or sleep off or do something is higher.
Yeah.
But if in Nigeria, you cannot put your car in cruise control because there are potholes. Automatically, some accidents cannot happen. Some types of accidents. It doesn't mean some other accidents cannot happen.
But I believe that let's leave the developed world now. I believe that even though I don't have a study to quote or showing Nigerian statistics, I believe that we are likely to have more unsafe surgeries down here compared to. There have been stories. People are scared of surgeries.
Yeah, so that's.
So how do we make surgeries safer?
Yeah, so first of all, we need to know what safe surgery is.
Mm-hmm.
Okay, so basically, in many places in Nigeria, we may not be able to use the word safe surgery if you want to go by WHO and worldwide, because safe surgery is not just the process of carrying out the surgical procedure.
Yep.
It's the whole process from seeing the patient,
mm-hmm.
investigating the patient, getting the patient to theater, what you do in theater and what you do post-operatively. So I give you examples. The cleaner is important in safe surgery.
Yes.
Because if the place is not clean, there's a problem. The process of sterilization is very important. You can see the place looks clean and looks beautiful, but your instruments are not well sterilized. You cannot carry out safe surgery. So even though you carry out safe surgery, it's not classified as safe anymore. If you don't have generator backup and you are doing major surgery, of course it's not safe surgery, because
or the procedure went smoothly, the surgeon has operated,
yes.
and then the post-op care is not optimum.
Yes, that is not,
which is even very important.
That is still not safe surgery.
All right.
So if you don't have appropriate sutures,
mm-hmm.
if you are supposed to use
snapping,
instruments are bad.
Mm-hmm.
It is the fact that you are using it doesn't mean you are doing safe surgery.
So what we want to try and bring down here is not just about the person doing the surgery.
Yeah.
That the person is competent.
Yes.
Now you didn't even mention anesthesia.
Anesthesia very important. Anesthesia is part of surgery.
Yes, so anesthesia.
If you don't have good anesthesia, or you are using wrong anesthesia for wrong procedures, that is unsafe surgery. So everything, gowning, everything that you do,
scrubbing,
to make sure,
draping,
yes, to make sure that the lighting, if you have bad lighting, bad surgery. So you find out that in our own setting, we already have a big problem, because most hospitals don't have the combination of all those things we've listed.
And it's not just about the doctors.
It's not about
the laboratory, the nurses, the doctors themselves, yes. The pharmacy. Everybody.
Everyone is.
And that's why sometimes I look at it, all these divisions and all that. We in Nigeria, we need to all come together and realize that the care of the patient is, we need to have this synergisms, be synergistic about it. It's not about this and that, everybody working differently, all coming together to care for a patient. Because as a surgeon, if your patient, you've operated well and all that, you've displayed skills and all, and then you probably will not sleep with that patient. I mean, what I mean by, you will not be there overnight. You've done the surgery and you have gone away.
Yes.
And maybe your residents are there giving you, updating you, you go there to check. But the people that will stay with the patient are the nurses.
Yes.
Now, your patient will need to get medications.
Yeah.
If the right medications or substandard medications are given, patient will come down with post-operative infection.
Sure.
So it's about everybody. Okay, so let's talk about pre-operative assessment, because I see that with this Japan syndrome, everybody, people moving abroad, and we still have people who will need surgery. Right here, a lot of expertise have gone abroad, but there are still people who can perform safe surgery in Nigeria as we speak. But because of the death or the dwindling number of expertise, you find a surgeon covering quite a number of places. How does that impact on correct pre-operative assessment and care for a patient?
Well, So I always say the training is the most important thing. Okay? So once a surgeon is well trained, he already knows what is required. Now let me give you an example. When you want to fly a plane, there's a checklist. The pilots and the co-pilots go through the checklist so that they don't leave anything. Of course, the same thing happens in theaters. There's a checklist that is recommended by the World Health Organization for use in theaters.
Yeah.
So when you are used to the process, even when you don't have the checklist in some circumstances, you are able to identify, no, that one is wrong. That should not be done. Because I imagine that same pilot in circumstances of war may not have the time to be going through the checklist one after the other, because you just have to run. But because he has used the checklist very many times, he's able to say, oh, let's do this, let's do this. The same thing happens in theater. Now, in preoperative planning, the surgeon is used to the way he prepares his patient. So he follows the process. The problem you may have when he has to cover multiple places is that the other people he's working with in those places are not used to what is supposed to be done. And that's where the problem comes in. So that's why in those places, and well, indeed, in every hospital, the younger doctors must be committed to care of their patients. They must know that they are not the ones primarily in charge of the patient, and they must confirm everything that they think should be done. They should confirm with the primary managing consultant. Because you cannot say, I just felt I should give this patient this fluid, when you've not confirmed from the consultant why he's giving this particular fluid.
Yep.
So, but nowadays, because people just have in their mind, they want to travel out of the country, they feel, well, let me just do whatever I want to do and leave this place.
Exactly.
But I don't think it should be so, because wherever you go, you need commitment as a doctor. If you travel to the US or the UK today, are you going to just manage patients anyhow? So for the time that you are still here, do it well. When you travel out, you continue to do it well, but don't think that you will do it badly here and then you travel out and now start doing it properly. So the fact that a surgeon is overworked or working in a number of places should not mean that he should now throw caution to the wind and just operate anyhow, because of course that would not constitute safe surgery.
So also still on the pre-operative assessment, patients can have comorbidities.
Yes.
So you are going to operate someone, person has hypertension or a heart condition or anything, and you need to operate the patient.
Yes.
I think one thing our people need to understand, but goes to the medical practitioner, doctors now, and the patient. It's not just about going into courts. The process of courting, the outcome of that courting probably would have, not even probably, will be determined by what you do for that patient pre-operative.
Yeah.
Yes, the intraoperative, the procedure itself is just a small fraction of the safety of that surgery. So it starts from history taking the right history. Oh, are you hypertensive? Getting to know the patient, knowing everything, so that you can assess the patient properly and know what, and be able to do risk stratification for that patient. Oh, what risk does this person have? And in line with the surgery that I'm going to do, how do I prevent the risk that this person has from impacting on my surgery, so that you can know what to put in place prior to the performance of that surgery. So all those things have to be done to make a surgery safe, and we need to really work on that. Now let's talk about people forgetting foreign bodies inside.
Yes,
we've seen a number of cases on the internet.
Yeah, so that's what is a bit more common here.
Yeah,
you will likely not find that in developed countries. But how do you prevent it? Is very, very simple. I mean, that's the simplest thing, and that's why you have checklists. Now, if you have a group of people and you are going on excursion, to the beach, what do? You count them now.
Yeah.
If you have 50 of you
Okay.
going for an excursion, you must be sure
And tag them even.
Yes, yeah. I will have 50 people. You count them as you are going in. You count them. Oh, 1, 2, 3. So 50. At the end of your excursion, you count them. Are the 50 complete? If you have 48, you cannot leave. That means 2 people are missing. Have they drowned? Have they been kidnapped?
Yep. Where is this thing?
Where are they? That is the same
I started this surgery with 5 gauze.
Yes, so you must count the number
for them.
of mops you are using. You count at the beginning of the surgery. The scrub nurse counts along with the circulating nurse. That's just our own terminology. And you have the number. When the surgeon is about to close, now if the surgeon is going to retain one of those sponges somewhere in the abdomen, he announces it that, see, I'm putting this in this area that we cannot see. I'm using it to, do one thing or the other. It might be to stop bleeding, but he announces it. So everybody is aware. And then if he forgets, everybody will say, have you removed that one you put in that place? Now, when he's about to close the abdomen or close the cavity, he asks the scrub nurse, is your swab count complete?
Yeah.
So at that point, the scrub nurse, along with the circulator, they count again to be sure that they have all their sponges with them. So if it's not complete, that means there's a sponge inside there and you must find it. You can't close up. So you see, it's so simple. But I think part of the problem is that some of these hospitals, they don't even have the full complement of staff. They might not even have a perioperative nurse.
They don't have a perioperative nurse.
If you don't have a perioperative nurse, you will likely have this problem more.
They are using...
No, you just don't have anybody. So the surgeon operates alone.
Yeah.
So sometimes they don't have real anesthetists. So there's a lot of struggling. When you have good anesthesia, there's a bit of relaxation when you're operating. But everybody is not running up and down. So if you give some kinds of drugs and the patient is not relaxed, there's a chance that you can make some more mistakes. If the patient is bleeding excessively and you are not in control of the situation, you are more likely to forget something.
I've worked in a place before that the surgeon is assisted by, I don't want to mention names. The surgeon is the one that will give anesthesia. The surgeon is still the one, if there's a problem, let's say a cesarean section, and the baby comes out flat, the surgeon is still the one that will go and resuscitate the baby. There's a problem, it's still the surgeon. That is not correct.
That's very, very bad practice.
It's not correct.
In today's, and while we say safe surgery, sometimes if you work in the village where you don't have a full complement of staff, there's nothing wrong in you assigning a nurse. The person may not be a perioperative nurse, but you assign the person to do the duties of the perioperative nurse for that
and the person understands.
The person understands that I'm supposed to count this and it must be complete.
Yes.
So you won't say that because you are working in the village where you have only 2 doctors in the whole village and you have 3 nurses.
You train people to bring people up to speed.
Exactly. So that is the way you can bring about safe surgery,
even in limited or resource poor environments.
So that's the difference. So that's why I say it is about the training of course, the surgeon is the one that is supposed to organize the team, especially in this environment. So that training of the surgeon will make him understand that this and this and this must be available for me to do safe surgery.
Okay, so second.
So that forgetting of swabs is more common here, and the only way to do it is just have your perioperative nurse and have them count your
or train someone to because we must not forget the fact that resources are limited in this environment, human resources, material resources, whatever. So even if we don't have as many perioperative nurses or people that can do that are supposed to be trained to do, there are people that can be trained to get the job done, although that won't be ideal, but we talk about appropriate technology given our setting. Also, I want to talk about the right expertise for a particular surgery. There's a saying that if you are going to perform a surgery on someone, that you should know the likely complications that can arise from that surgery, and probably be able to handle it, or have someone that you can readily call to handle the surgery. I know you've mentioned many times that people will open up a patient and then they thought of something before entering, but they met something else, and then they close the patient up. What's the worst that you have seen?
I can't even count.
Okay.
I can't count, but it's just what comes to my mind now. I've seen somebody operate on a patient with a strangulated hernia.
Okay. What does strangulated
hernia? Yes, strangulated hernia means that, usually when there's a hernia, that means there's a hole. There's a hole that allows something to escape from where it naturally is. So if I have something in the abdomen, in the tummy,
okay,
and then there's now a hole, in this case, between the abdomen and the scrotum.
Yep.
So intestine then goes from the abdomen into the
enters
scrotum. But most times, in most people, it comes
and
it goes out, comes back,
retracts and all that.
But if it goes in there and it gets stuck, maybe because of the neck that is narrowed. If it gets stuck, it means that intestine is unable to come back inside.
Yeah.
And then blood is not able to get there. If blood does not get to any organ, it will die off. So strangulated means that it has lost its blood supply and become gangrenous. So it's dead. That part of the bowel of the intestine is dead. What you're supposed to do in that situation is, when you open up, you're supposed to cut off the dead intestine and join the normal intestine or the healthy intestine. But this person opened and they saw that this dead intestine, and he could not handle it. So what did he do? He pushed the intestine back.
A strangulated
intestine that is already dead. He now pushed it back, closed up, and then referred the patient. Now, what he has automatically done is that he has killed that patient. And the reason is because inside that dead intestine, there are a lot of toxins
that are going to be released.
Yes. So it's those toxins that will kill the patient. Meanwhile, when the intestine was in the scrotum, it was even a bit better off because it's outside of the abdomen.
Yeah.
But now you have pushed it into the abdomen. You have pushed.
Because they generalized.
Very, very bad inflammatory process. Of course, the patient is going to die. There's no two ways to it. So I usually say that yes.
So can I narrate? There was a day I was operating, talking about skill to handle a situation. So I did a cesarean section, entered, delivered the baby, but this uterus will not just contract. I mean, the woman was so flabby and all. I was not comfortable. Fortunately, the woman wasn't bleeding, which was strange. She wasn't bleeding. I had to get someone. Of course, I checked. There was no bleeding. Vital signs were stable, but I was still not comfortable returning the uterus. Of course, I done different things. Tried to put the uterus back in the abdominal cavity to see whether it was going to contract and all. No, it didn't contract as I expected. So I had to invite someone else, of which I knew, of course, there was, where I practice, the support system. If a consultant needs help, you can readily call several other consultants who at your beck and call that can come to the rescue. So I called the OBGYN, who came in phone call away. He didn't scrub in, he didn't need to, he joined me in theater, looked into it, we talked, deliberated together. He felt, return the uterus, let's cover with oxytocin. The patient is going to be fine, let's monitor. So we closed up, and unfortunately the patient was not bleeding.
Fortunately.
But we loaded with oxytocin and all that. I had the backing of several other people. But I've seen so many cases of PPH and all that. The person doing the cesarean section. A cesarean section does not have the skill, or they don't even have the skill to resuscitate a baby. Let's even start from there. So baby comes out flat. There's no skill to resuscitate the baby. There's a complication from cesarean section. There's no skill to handle whatever complication, or you don't have anybody to readily call. And maternal mortality in Nigeria is the highest. And so those are some of the things contributing to maternal mortality in our country. So, what's the solution to this?
So we always say, well, they used to say that if a surgeon will do a particular procedure, he must be able to do a secondary procedure in case what you find is more complicated.
Yeah.
But what I say is that may not always be possible.
Okay.
However, what I know is that a well-trained surgeon is always, or a well-trained doctor would always make a good specialist in whatever field. Meaning that I gave you the example of the hernia. That diagnosis should have been made before the surgery.
So the person should have known that this
one, I should not touch this one. So this one,
you choosing your cases.
Yes, you choose your case and say, no, this one, just go to this person. So if you are a good doctor and you want to operate, there will be cases that you say, no, this is not a straightforward case.
And it doesn't mean you're a bad doctor or your ego. It's not about ego here. You're saying that I do not want to handle this particular case. Doesn't mean that you are not skilled. In fact, it shows that you're a good doctor.
Yes. So if appendectomy can be a very simple procedure.
You see?
But
people have died.
You don't have to do every appendectomy if you are not trained to do very complex procedures. Because you can do an appendectomy and then you go in there and you find something very, very complex and you need to do something extra. So if you want to remove the chances of you having to do that extra, then you will send
the decision to take the surgery. You must, do I take this or not?
Yes. So that's what you need to do. Are you doing this case or not? Now that's the first step. Second step is support.
Yeah.
So if you are doing a case, you need to have support. You have to have a plan that if I meet this problem, is there someone I can call?
Do I have equipment?
Do I have equipment to do this? Do I have, because sometimes if you have to close up the patient, like the case of a strangulated hernia, you already know based on principle that you cannot return bad intestine into the abdomen.
Wow.
So the worst you are going to do is to leave that intestine outside until somebody who can resect it comes. So meaning that you must have somebody that can come within the hour to rescue you. So the first step is be careful with the cases you choose. Second step is have the support around you.
A network of people at your beck and call.
Yes. So very, very important. Now the third thing is when you then need to refer the patient, don't just send the patient out of your hospital as if it doesn't concern you, because that's what many people do. You just say, go to teaching hospital. Which teaching hospital? Have you spoken to anybody in the teaching hospital that will accept the patient? Are they aware the patient is coming? Or the patient will just go on the queue from your hospital, goes on the queue and is going to, and then they will
like one has sentenced that patient to death,
and you collected their money. So patients, doctors or healthcare workers must be committed to their patients, such that even when they are leaving your facility, you don't just say leave the facility, at least you are off my neck.
They are off my neck.
You must be committed to making sure that they recover from whatever it is you started.
And that brings me to the bi-directional referral system. So ideally it should be such that you are referring someone out. There's a way you can get feedback from where you are referring to, or you can't just refer if you have not established a rapport with the system or that you are referring to, especially in our Nigeria, especially in this country. There's one other aspect of safe surgery that time will not permit us to talk about. I don't want this we don't want this video to be too long. I think we would have to talk about safe surgery again, because there are some aspects we have not been able to touch. All right. Any final words?
So it's very simple. Like I said, a well-trained doctor is supposed to be a safe doctor.
Mm-hmm.
So if that's a safe doctor, if the person happens to go into surgery, the person should end up being a safe surgeon.
Yeah.
And a safe surgeon would not be able to do all procedures.
A safe surgeon, please repeat that.
Yes, so a safe surgeon is not supposed to be able to do all procedures.
A safe surgeon is not supposed to be able to do all procedures. You should understand your limits.
So,
sometimes ego.
Yes, ego, yes. Sometimes there are many factors and we learn over time. We learn, we improve. Sometimes we've done procedures that you ask yourself, should I have done this procedure? And then as you become more experienced, you tell yourself, no, I'm not going to do these ones. There's no point in doing this. So it's important I think the word I want to give to patients or people listening is that they need to identify safe places to go for their procedures.
Yep.
Don't just go to any hospital for the sake of it. Be sure that you have safe doctors, safe hospitals. Because if you ask me now about a particular procedure and I can't do the procedure, I will then send you to another safe facility.
Safe facility.
That's the way to go about it, and everybody is going to be safe. So surgeries are mostly safe. All these things that people say about this person did the surgery and died, they are not true. They are mostly not true, except for the fact that those things have been done in unsafe conditions and unsafe facilities.
Well, that's not to say that depending on the severity of the case, the chronicity of the case, what do you guys, there are certain procedures that that are very risky, and of course they are not. The chances the survival rates are very low. So we are not saying that things cannot happen. A patient can still have the best of facilities, best of expertise, best of everything, and still die. But it should be that everything has been done, or everything from the pre-op till post-op, things have been done. The other areas I would have loved us to talk about: informed consent, issues of
those ones are separate.
Yes, but people understanding the risk of it's not really part of safe surgery, but understanding what it's still. For example, let's say you have planned for a particular procedure, but a complication arises and you need to take a decision at that point in time. If you are told, you have envisaged it, you have talked about it before, and the patient already probably signed to, okay, in case of this arises, I permit you to go ahead. All those things are very important too.
Those are separate discussions.
Yes, that's what I'm saying. We are not going to talk about those things here because of time. We don't want this to be too lengthy. I hope you have learned one or two things from our discussion today. So if you really need surgery, it can be safe if you identify a good facility, a good doctor, a good team. Not just a good doctor, a good team. There's a rapport between you and your team, and then we put the rest in the hands of God. All right. Thank you very much for watching today's episode. I'm Dr. Dami, and I want to thank our General Surgeon, Dr. Ilemile, who has been answering all my questions. This is Dr. Dami Med TV. Please like, share, subscribe so that we can bring you more discussions like this. See you next time.